Good morning, everyone. Welcome back to our seventh scientific session. Good morning to the people who are watching virtually. Good to see you all again this morning. And it's my pleasure to introduce Dr. Sally Carty as our distinguished moderator this morning. And I'm going to turn the podium over to her.
Good morning, surgeons and wonderful trainees of all sorts. In this brief talk, I'm going to try to read the notes and try to focus on what we can learn from the abstracts that are in this session. Here are my sources of support. I have no conflict of interest. Next slide. And in particular, my employer does not know or care what I work on, which is it's a shame that I sometimes have to emphasize this in talks. If anything, they'd prefer that I didn't work on anything and build more. Whoops, go forward. But I do have a confession to make. I started out hating to do thyroids. When you do a lot of anything, I had to learn to like it, you have better outcomes, and you certainly get nerdier in talking about it and writing about it as I have done. And I'm grateful to all who have helped evolve the field from patients, thyroidologists, and the national budget. This is our wonderful thyroid group. Do I have a pointer? Showing endocrine surgeons, otolaryngologists, endocrinologists, and radiology is the whole back row. And all of us manage molecular results constantly in clinic, in endless electronic medical records. And the question is still, as it was 100 years ago, is it benign or malignant? And for that, we do diagnostic lobectomy still, which is a disappointment. Here you see Theodore Coker, who got the Nobel Prize for thyroid surgery. It was really dangerous then. And here is fine needle aspiration biopsy and innovation. It still carries safety issues and risk. There have been sequential innovations for thyroid nodule management, a lot of them lately. And the one I'm going to focus on now is preoperative molecular testing, which has been in routine clinical use in the US since 2008. So that's 14 years. That's a lot of data. I've done about 7,000 thyroidectomies. That's about 14,000 new patients with thyroid nodule disease, and I've used molecular to assess about 1/5 of them. Molecular testing was designed by various very smart people to break the 3 orange groups, the indeterminate Bethesda cytology categories, into Bethesda 2 benign or Bethesda 6 cancer. It doesn't always work, but it's helpful in doing so. And there are 3 current molecular tests listed here, and I use each of these all the time. But first I had to learn from Brian Haugen in the ATA guidelines about the levels of clinical testing, which, as you see, are analytical validity, and clinical utility. Going to the middle category, clinical validity, there are lots of studies that have shown accuracy, sensitivity, specificity, NPV, and PPV from various types of molecular testing, and they've all morphed over time to become more and more like each other. And then there is clinical utility testing, which is the hardest to do, and which actually is the crux of value. Listed here are just the major studies, and I apologize if there wasn't room to list yours. As you can see, the middle test, Thigenex Thyromere, is significantly understudied. But the other 2, Afirma-G SC plus XA and ThyroSeq version 3, have robust clinical validity testing. And go to the last column, clinical utility. In red, we see a wonderful paper from Dr. Ye's group at UCLA that randomized patients to GEC, or ThyroSeq version 2, and found a robust reduction in unnecessary thyroidectomy, in lobectomy for benign disease. Multiple other studies have confirmed that when you use molecular to sort out people who can be actively surveyed versus surgery, you have less surgery. In red, we see the cost efficacy study by Kia Nicholson and my wonderful partner Lin-Hua Yip that robustly showed cost benefit for any molecular test, Afirma GSC or ThyroSeq version 3 versus diagnostic lobectomy. And this finding was confirmed by Kyle Zanako's paper that looked at GEC and found for ATA low-risk nodules cost benefit against diagnostic surgery. And the last two in red are studies that showed clinical utility as far as increasing the rate of histologic cancer. The one by Guan showed a threefold increase in histologic cancer for all RAS nodules, and the one by Cardi, Lynn was very patient with me, thank you, Lynn, showed a fourfold increase in the rate of histologic cancer. In other words, we're operating for cancer, we're not operating for benign nodules. The last study also showed, for the first time, the safety of active surveillance in short-term follow-up, 2 years of follow-up. Now, here's some other handy features of molecular, but the main thing is BCR. Benign call rate is the percentage of indeterminate fine-needle biopsy that are molecular negative. And if you live in a red state, listed here, Pennsylvania is red, you have a high baseline rate of cancer, high pretest probability, and therefore possibly a higher BCR. If you live in a blue state, you have a lower pretest probability, but the point is that all the BCRs for all three tests are very good. Now, our job as thyroid surgeons is to be decent people and then decide whether to operate and then decide what operation to do. And the ATA guidelines for thyroid surgery lists table 11, which gives clinical factors that favor initial thyroidectomy versus lobectomy, which is what you think about all day in clinic. However, it also has recommendation 10, which says don't get molecular if you're not going to need the information. Don't waste the money if you've already decided to operate. Hi. So now some real-time examples that I really can't read, but and you know they're real-time because of the bad Xeroxing. This lady has a 2.7 centimeter TI-RADS 3 FN that was ThyroSeq negative with an estimated risk of malignancy of only 4%. I recommended active surveillance. This patient has a 1.3 centimeter AUS, and her MT showed low-level KRAS with an estimated risk of malignancy of 5 to 10%. In discussion, she decided for active surveillance. Today, we'll hear from Dr. Hunter Underwood about a study of shared decision-making with patients in low-risk thyroid cancer. This patient had Afirma GSC for a 2.2 centimeter FN that was GSC suspicious. Expression Atlas didn't show any specific mutations. Under the ATA guidelines and the AAS guidelines, there was no identified reason for initial total thyroidectomy. So I recommended lobectomy, however, she had a particular reason that would make it high risk. And so in discussion, she decided not to have surgery. Are you getting the drift here? So far, all of these patients have not gone to surgery. In a recent validity study, there's a high risk of malignancy for IFAX1 when it's splice site mutation plus other mutations. And this patient, as you can see, had HRAS, GEA, gene expression alterations, and a splice site IFAX1 with a risk of malignancy of 70%. It's tempting to recommend total thyroidectomy, but there's no current data that support the use of molecular in deciding what initial surgery to do, and I recommended lobectomy. This patient had AUS with 3 different mutations, HRAS, TERT4, copy number alterations and gene expression alterations with a high estimated risk of malignancy of 95%. My partner did initial total thyroidectomy incorrectly because it turned out to be a bad, poorly differentiated big cancer with angio and lymphatic invasion, and on PET and RAI with bone and liver mets. So this lady's initial prompt total thyroidectomy helped her get right to her necessary adjuvant care. And here's the last example. Molecular results, and there's many examples. We had many meetings about which slides to include. Molecular results do not supplant standard care or judgment, never. This patient had an ordinary AUS nodule that on Thigenex Thyromere had a risk of malignancy of 15 to 20%. She was referred for diagnostic lobectomy, but it was the beginning of the pandemic. So 8 months later when she got here, it had nearly doubled in volume by ATI criteria. I did a lobe. It was invading, adherent to the IJ and the nerve, and turned out to be a bad Hürthle cell cancer with a 10% anaplastic component. Her medical oncologist, looking for a systemic treatment target, got ThyroSeq version 3, and she had multiple chromosomal copy number alterations, TP53 mutation, and VHL mutation. All of those conglomerate abnormalities would predict prognosis by an increasing body of data. Here's a paper from 2015 that shows genotype-phenotype correlation. It's important when just looking at genotype-phenotype correlation to realize that BRAF V600E, which got a lot of initial attention 10 and 15 years ago, does not independently trump histology. It predicts histology, but if you stratify by histologic features, its predicted power goes away. However, TERT is a really big deal in predicting survival, as these 3 studies show. Here's the 3rd one. And today we'll hear from Dr. Jason Liu about his new Kaplan-Meier curves for molecular risk group prognostication. Now, this famous figure from the ATA guidelines listed only BRAF V600E and TERT among its histologic features ranked by risk of recurrence. But as we now know, lots of other molecular abnormalities can be grouped by their risk of aggression. In this recent study, specific molecular abnormalities were used to stratify patients into high, moderate, and low risk groups that then, on the right, robustly correlated with the risk of distant metastasis, the presentation. Specific results can also allow prospective full IRB trials about can molecular help you decide what initial study to do. This trial of Dr. Yips is now multi-institutional with Dr. Tracy Wang, lacks only 3 patients to close. So some have said, can't we use ultrasound patterns and clinical factors? Do we have to get these stupid molecular tests? And the answer is, no, we can't use them, at least not yet. In this study, led by Jim Figge, multi-institutional blinded study from last year, the question was, can molecular be replaced by clinical parameters or ultrasound? And the answer is no. In multivariate and sequential nomogram analysis, neither of them were as potent as molecular by a factor of 18. Today, we're going to hear from Dr. Kyla Wright that TI-RADS 5 designation does not predict thyroid cancer as well as initially thought. And if I had a pointer, I could draw your attention to the bottom where TI-RADS 2 cancer risk is higher than for TI-RADS 3 or 4. So, what molecular tests should we use and when? This figure from the ATA guidelines lists things that you should think about in deciding whether to do a lobe or a total, but it had flawed logic because in blue are the only things that you can know about preoperatively. The conventional advice, remember the regional cancer prevalence concept, is that use GSC when you live in a blue state or when you have low cytologic expertise, and use ThyroSeq version 3 when there's high cancer prevalence or when you care about specific molecular information and or prognostic information. But that's not what I recommend. What I recommend is, it doesn't matter what test you use. The important thing is to use one. It saves money compared to diagnostic lobectomy. Now, people sometimes say this is too complicated or dumb for me to master. And no, actually you're all really smart. And it's just like the huge breast cancer literature in surgical oncology. Once you master that literature, you use it all day long in talking with patients and in thinking about clinical care. So my advice, last slide, is master it. It's interesting, it's not that hard. What we've reviewed today is that clinical validity, the accuracy of molecular testing is well described and validated, that the cost-efficacy versus diagnostic lobectomy is confirmed, and that using molecular to select patients for surgery versus surveillance is effective and safe, but the safety needs confirmation, at least in my opinion. As far as prognostic use, molecular as a prognostic tool is described, but certainly needs confirmation, and using it to determine the correct initial extent of surgery is unknown. Thank you. Okay, now Dr. Ganley is going to take us through our first talk. 3 of the 4 talks in this session are videotaped.
Great. Thanks, Sally. My name's Ian Ganley, one of the attending head and neck surgeons from Memorial Sloan Kettering. And the first talk that we're going to do is by Hunter Underwood, and he's going to discuss what do patients want to know about surgery for low-risk thyroid cancer, a qualitative study.
Good morning, and thank you for the opportunity to present our work today. My name is Hunter Underwood, and I am the current endocrine surgery fellow at the University of Michigan. Today, we will be discussing our paper, What Do Patients Want to Know About Surgery for Low-Risk Thyroid Cancer, a qualitative study. This study was funded by an NIH-K award from Dr. Susan Pitt. The incidence of low-risk papillary thyroid cancer continues to increase globally. A majority of patients ultimately undergo total thyroidectomy. However, active surveillance and thyroid lobectomy have emerged as acceptable treatment options without significant differences in disease-specific survival or recurrence in appropriately selected patients. Surgeons often attempt to engage in shared decision-making with patients to select the treatment options that best balances the risks and expected outcomes with patient preferences and values. The process of shared decision-making, however, requires significant patient education from the surgeon, as well as activation from the patient to ask questions and express his or her values. Previous work has elucidated the unmet needs of patients with thyroid cancer, as well as the influence of emotions related to being diagnosed with cancer on treatment decisions. Little is known, however, about the cognitive content of treatment decision-making, the topics that patients with thyroid cancer prioritize, and the gaps in understanding that may remain after initial surgical consultation. Thus, the objective of our study was to better understand the information that patients desire regarding various treatment options for low-risk thyroid cancer in order to improve patient-surgeon communication and the overall experience of future patients. This study was conducted at 2 academic hospitals in the United States to provide geographic and institutional variability. All attending surgeons, including endocrine surgeons and otolaryngologists who perform thyroidectomy, were invited to participate. Adult patients were eligible to participate if they were English-speaking and had clinically low-risk thyroid cancer, which was defined as biopsy-proven papillary thyroid cancer or cytology suspicious for papillary thyroid cancer, without high-risk features. For the purposes of this study, high-risk features were tumor size greater than 4 centimeters, suspicious lymphadenopathy on physical exam or ultrasound, and preoperative evidence of extrathyroidal extension. Patients with a history of thyroid surgery or parathyroid surgery were excluded from our study. All participants provided written consent in person before the visit. Patient-surgeon consultations with family members as present were audio recorded and transcribed verbatim. All identifiers were removed from transcripts before analysis. Participants did not have access to the study data or results. Data collection continued until no new themes emerged or data saturation was reached. A code was developed to catalog unprompted substantive questions that may impact the treatment decision. Overall, 28 of 30 patients with low-risk thyroid cancer who participated in our study asked 253 substantive questions. 2 patients did not have any substantive questions during their consultations. Patients ranged from 20 to 71 years old, with the majority identifying as white and female. Participating surgeons had been in practice for 2 to 50 years. Most surgeons were white and men. A majority of surgeons were endocrine surgeons, and the remaining were otolaryngologists. A majority of our surgeons participated more than 50 thyroidectomies per year. Major topics among substantive questions identified in order of frequency include the extent of surgery and active surveillance, the practicalities of thyroid hormone supplementation and radioactive iodine, and the etiology and prognosis of thyroid cancer. Within conversations, surgeons often provided significant education to patients among these topics while simultaneously introducing various treatment options and their associated risks and benefits. Patients would then respond with clarifying substantive questions or novel questions related to different topics. Among the major topics identified, patient substantive questions regarding the extent of surgery for low-risk thyroid cancer were the most common. Before patients had the opportunity to ask questions, most surgeons explain the surgical and non-surgical management options. Surgeons would often focus on describing oncologic outcomes and surgical risks, such as nerve injury or hypoparathyroidism. Surgeons less commonly discuss the potential need for thyroid hormone or completion thyroidectomy to facilitate radioactive iodine administration if needed. Patient questions, however, focused on obtaining a direct recommendation from surgeons with questions such as, what would you do? And do you really not think there's a right answer? Surgeons usually responded indirectly to these questions with statements such as different strokes for different folks, or it's ultimately up to you, leading to the question as to whether or not most surgeons were actually participating in shared decision making. In regards to active surveillance, surgeons would often describe different types of patients that may prefer each option, with active surveillance for older or sicker patients and surgery for younger or healthier patients. Surgeons would often use effective forecasting and stating that patients would be able to move on with their life, and with surgery they wouldn't have to worry about it in the future, making the assumption that all patients would have significant anxiety regarding their diagnosis. Patients were often concerned about the risk of progression with active surveillance and wanted to know specifically the risk of spreading or if the nodule would grow before it spread to the lymph nodes. Patients also wanted to know what criteria surgeons would use to determine if they would ultimately need surgery. Surgeons would then reassure patients that they would be able to opt out of active surveillance at any time with minimal cancer-related morbidities. When comparing total thyroidectomy versus lobectomy, surgeons often discussed, unprompted, the certain or potential need for thyroid hormone. Given that it's impossible to predict who needs hormone replacement after surgery, this discussion was not always presented as a clear advantage. Surgeons rarely talked about laboratory monitoring of thyroid hormone or how hormone replacement might affect the patient's quality of life. Patients asked questions to clarify how it would be determined if they would actually need thyroid hormone. Patients were also curious about potential side effects of the hormone, such as weight gain with inadequate dosing. Surgeons reassured patients that thyroid hormone is well tolerated with minimal side effects. A few surgeons mentioned that some patients have chronic issues related to thyroid hormone, but didn't specify much further. Radioactive iodine was a major topic that some, but not all surgeons introduced unprompted, early in treatment discussions. Surgeons often de-emphasize radioactive iodine as a less important adjunct to surgery because it is not indicated for all patients and is used less commonly than it was in the past. Most patients had significant substantive questions about radioactive iodine if the topic was introduced by the surgeon. Many asked questions about the likelihood of needing RAI and what the indications would be. Others asked clarifying questions to understand how the extent of surgery will relate to RAI administration. Despite initially introducing the topic, most surgeons did not want to discuss radioactive iodine in depth during the initial visit, responding with statements such as, it will confuse you more than it will help you, and you need to think about the surgical issues. A majority of unprompted surgeon-provided education centered on the prevalence of thyroid cancer in the general population and the incidental nature of discovering thyroid nodules. Surgeons would often frame thyroid cancer as a slow-growing and indolent tumor that does not behave like other cancers in the body. Surgeons also reassured patients that the diagnosis would not be life-limiting. Surgeons explained that the goal of initial therapy was to decrease the risk of recurrence while simultaneously minimizing overtreatment. After education, patients were often interested in both the duration and the etiology of their disease. Patients asked questions such as, could I have had this for years, or what do you think caused the cancer? Patients were also concerned about the potential of cancer spreading or metastasizing. Several patients inquired about the stage of their cancer. Several patients made comments connecting their cancer diagnosis with symptoms classically related to hypo or hyperthyroidism, such as weight gain. Surgeons answered patient questions by providing more education that was intended to be reassuring. Only after being prompted by patient questions did surgeons explain the possibility and implications of local regional spread and the low risk of distant metastases. In summary, our surgeons spent a great deal of time educating patients about treatment options, however spent less time engaging in shared decision-making. Patients asked several substantive questions after surgeon-provided education about the disease, management options, side effects, and adjunct treatment, suggesting that communication gaps still remain. This lends to an opportunity to provide surgeons with resources such as pamphlets, videos, decision aids, and training to better anticipate and address the information to improve shared decision-making process among patients with low-risk thyroid cancer. Thank you for the opportunity for us to present our work today, and we look forward to answering your questions.
Okay, thanks. Thank you very much, Hunter. That was an excellent presentation. We have the floor open for questions. And could you state your name and institution, please?
Brad Mitchell, Dover, Delaware. Hunter, thank you very much for this interesting presentation. I think it's really terrific. I guess I have a couple thoughts. One is the questions that the patients don't ask. I often find that many of the patients, I think, walk away. I've explained to them as best I can the prognosis and the considerations that I think are important. But I often feel that they walk away and then somebody says, oh my gosh, you have cancer, you better get it out of there. and that leads to them favoring total thyroidectomy and radioactive iodine. I just wonder if you have any thoughts. And then last comment, I really appreciated your proposal that we have video aids, and I think it would be a great thing for AAES to work on creating such material on our website.
Thank you. Yeah, I think it's very difficult for most of these patients as they come in and they're receiving a scary diagnosis such as cancer. And despite us reassuring them and telling them that it's going to be okay, there's not great data that exists on the internet to provide them with information they might need, especially after their consultation, even though we do the best we can. So I definitely think that decision aids that we're working on developing and will be the topic of further research will help make those situations happen less often.
Mike Demirth, thank you, Hoag Hospital in Newport Beach. I really appreciate your talk, and it highlights the thought that the communication isn't what we tell the patient, it's what they hear or what the message they receive. And your project goes a long way to receiving that because the questions are asking. I think the other question maybe you could address is in the context of the 2015 ATA guidelines, it seems like our discussions, there's more options. I mean, patients used to get a total thyroidectomy, almost everybody, and now we're spending more time talking about the pros and cons. And how often did patients address the fear of needing to come back for further surgery, or how surveillance might be different?
That did come up occasionally, but not very often. And a lot of that is framed in terms of what surgeon education was provided. So most of our surgeons did not, directly bring up that topic unless they were asked. As it did not come up that much as a fear that patients had.
Okay, we'll take a question from the right, from Sarah, please.
Thank you, Parangi Boston. Thanks for this great study. I guess my question is, what about the role of the endocrinologist and how can we better partner with our endocrinologists? Because certainly I'll say that I've learned from a few years where I kind of took the helm for active surveillance, that it's actually better for my patients if I strongly partner with an endocrinologist and let them take the helm after the visit, after this visit where you discuss it. So I was wondering, what are your thoughts around the information coming from the endocrinologist and how we can better partner with them?
I can completely agree with a lot of your thoughts. I think that endocrine surgeons were put in a unique situation where we're often on the front line of seeing a patient with a diagnosis of thyroid cancer. And a lot of the long-term issues that patients are going to face, whether they decide on surveillance or they end up getting surgery if they require thyroid hormone replacement or radioactive iodine, a lot of that's going to be followed up by, not us, by our colleagues in endocrinology. So I think the solution to working better with them, one option is really having a good multidisciplinary clinic in terms of, a patient can see a surgeon and an endocrinologist on the same day. So all stakeholders, including the patient and the people that will be following in the long term are involved. But I do think that providing a lot more education in terms of pamphlets or decision-making aids that will go over the information that a lot of endocrinologists would also go over will be helpful for patients in the future.
Okay, thanks very much, Hunter. Unfortunately, our time is up for this talk. We have to move on to the next one.
Now we're going to hear from Dr. Kyla Wright about the clinical significance of ACR TI-RADS 5 thyroid nodules, not as risky as we think.
Hi everyone, thank you so much for allowing me to speak with you all today. My name is Kyla Wright. I'm a third-year medical student at NYU, and today I will be discussing our project entitled The Clinical Significance of ACR TI-RADS 5 Thyroid Nodules, Not as Risky as We Think. Here are our disclosures. So as you all know, the prevalence of thyroid nodules in the general population is high. To help us categorize thyroid nodules based on likelihood of malignancy, several sonographic risk stratification systems have been created. One of the most widely adopted is the American College of Radiology Thyroid Imaging Reporting and Data System, also known as TI-RADS. As you can see here, the ACR TI-RADS system sums 5 sonographic features, including composition, echogenicity, shape, margin, and echogenic foci, to determine nodule risk level. Nodules receive points for concerning features such as solid composition or irregular margins, and using the scoring system, nodules are stratified into 5 different types. Together, a nodule's TI-RADS classification and its diameter guide whether FNA biopsy is recommended. Nodules earning 7 or more points are classified as highly suspicious, also known as TR5 nodules, and these TR5 nodules will be the focus of our presentation today. Malignancy rates among TR5 nodules are reported to be as high as 87% in prior studies. Accordingly, guidelines recommend further evaluation with FNA biopsy if greater than 1 centimeter in diameter. However, we currently have several additional tools that help us to risk stratify these nodules beyond just sonographic characterization, including the Bethesda system for reporting thyroid cytopathology and molecular testing assays. Yet, few studies have reported malignancy rates among TR5 nodules using these additional tools, and even fewer include data on histopathological diagnosis. In our own practice at NYU, we've noticed that very few of these TR5 nodules end up being malignant. To get a better sense of the true malignancy risk of these nodules, we aim to 1, re-examine the clinical significance of TR5 nodules when supplemented with cytology and molecular testing, and 2, to assess the performance of the current TI-RADS system in differentiating benign and malignant thyroid nodules at our institution. To do this, we reviewed all patients at our institution who underwent FNA biopsy for TR5 nodules between January 2018 and September 21, and FNA biopsy results were characterized using the Bethesda system. For the purposes of this study, both Bethesda 5 and 6 nodules were considered malignant. Molecular testing was routinely performed with ThyroSeq for nodules with indeterminate cytopathology, and molecular testing results indicating a malignancy risk greater than 50% were considered positive. For our analysis, nodules with malignant surgical pathology results were compared to those with benign. On surgical pathology, NIFT-P nodules were considered a distinct clinical entity, and all of our analyses were repeated, once with NIFT-P nodules grouped as malignant and once with them grouped as benign. So in total, we identified 496 TR5 nodules at our institution, and here you can see the breakdown by Bethesda category. On cytopathology, we found that most nodules, around 73%, were benign, whereas only 12.3% of nodules were malignant. There were 57 nodules with indeterminate cytopathology in our study, and of these, 53 had molecular testing, 24.5% of which yielded positive results. In total, 42 nodules underwent surgical resection. 78.6% were malignant, 7.1% were NIFT-P, and 14.3% were benign. Of the malignant nodules, pathological diagnoses included 32 papillary thyroid carcinomas and 1 medullary carcinoma. Breaking this down by Bethesda category, though most TR5 nodules in our study were benign on FNA biopsy, as to be expected, very few of these nodules were resected. And of the resected Bethesda 2 nodules, 80% were benign on surgical pathology, and there was 1 NIFT-P nodule. On the other hand, 27 nodules with malignant cytology underwent surgical resection, and we found that all of the resected TR5 nodules with malignant cytology were malignant on histopathology as well. Of the TR5 nodules with indeterminate cytology and positive molecular testing results, 7 underwent surgical resection, and 57.1% of these were malignant on final histopathology. So we then compared benign and malignant nodules, and we found that the total number of TI-RADS points was higher on average in the malignant nodules. As we discussed previously, 7 TI-RADS points designates a nodule as TR5, and in our data, the mean number of TI-RADS points was close to that cutoff at 7.3 in the benign nodules. In contrast, the mean number of TI-RADS points was higher at 9.2 in the malignant nodules. And this held true when NIFT-P nodules were analyzed as either benign or malignant. Next, we compared the individual sonographic features of the TI-RADS system between the benign and the malignant nodules. And we found that there were discrepancies in points assigned for nodule composition and echogenic foci. As you can see up top, points were allocated for inability to determine composition in 33% of benign nodules versus only 3% of the malignant nodules. In addition, shown at the bottom there, points were allocated for macrocalcifications in 50% of the benign nodules versus only 6% of the malignant nodules. And again, both of these results were similar regardless of whether NIFT-P nodules were analyzed as benign or malignant. So this prompted us to take a closer look at the resected TR5 nodules that received points for the presence of either of these two features. And we found that 2 benign nodules would actually reclassify as TR4 without point allocation for macrocalcifications. And for both of these nodules, FNA biopsy would no longer be recommended given their size. On the other hand, the 2 malignant nodules with macrocalcifications maintain their TR5 designation without these points. Similarly, 1 excised benign nodule that was allocated points for inability to determine nodule composition would reclassify to TR4 without these points, and biopsy would no longer be recommended. And again, the malignant nodule maintained its TI-RADS 5 designation. So in summary, the malignancy rate among TR5 nodules in our data was only 12.3%. In addition, all resected nodules with malignant cytopathology were malignant on histopathology as well. And lastly, TI-RADS point allocation for macrocalcifications and inability to determine nodule composition were more frequently observed in benign nodules. Excluding point allocation for these features resulted in 3 benign nodules reclassifying as TR4 with an associated change in recommended management. On the other hand, excluding point allocation for these features in the malignant nodule did not change TI-RADS classification. Limitations to our study include its retrospective design and small sample size. Future directions include similar studies with larger sample sizes and across multiple institutions. In addition, while data regarding radiologist experience or inter-observer variability was not collected in our study, future studies may explore inter-observer variability in the TI-RADS points assigned both within and across institutions. In conclusion, TR5 thyroid nodules may be associated with a lower risk of malignancy than previously reported. In addition, certain suspicious features included in the current TI-RADS system do not appear to perform as well in differentiating benign and malignant nodules. And though variability in sonogram interpretation may contribute to these findings, modification to the ACR TI-RADS system may be appropriate as additional data emerge. Thank you all so much for your time, and special thanks to Dr. Suh and Dr. Patel for their mentorship on this project.
This excellent paper is open for discussion. Dr. Fraker.
Thank you very much. Very nicely presented. So, Doug Fraker, Philadelphia. Probably a dozen times a month, I have outside patients. I get a lot of patients from other systems with TR5 nodules. We re-review them as TR2, TR3. It's mostly colloid flex are misinterpreted as microcalcs. When you did your subset analysis, you downgraded some. Mm-hmm. This is really different than other people's data. I would suggest that it's not that the nodules may not be that, TR5 may not be that worrisome. I say TR5 at NYU may not be that worrisome. And I'd like to hear your comment on that.
Yeah, thank you so much for your comment. I think I definitely agree. There's definitely a large amount of variability that has been shown in previous studies between different institutions in how radiologists are calling different nodules and what features they're assigning to these nodules. I think, at our institution, it's going to be an ongoing project, and our next steps with regards to this project are going back through these nodules, looking at the radiology reports, looking at radiologist experience, comparing who's calling what, and then being able to have a discussion with our radiology team. And then I think we need larger multi-institutional studies to be able to more definitively say how we can modify the TI-RADS system on a national level to account for the variability between institutions. Thank you.
Dr. Wilhelm.
Scott Wilhelm, Cleveland, Ohio. Very nice. Just a quick comment. So just kind of reflecting back to the last paper and the theme of this session too. So when we talk about surgeon-patient interactions, when you talk about TI-RADS to patients, one of the things I always throw out to them is I don't actually use the true acronym, and I call it Thyroid Imaging Radiographic Score. And I give that to the patient. I obviously wouldn't report that in the literature, but it's a way of at least telling people we're giving you a score to try to help guide what TI-RADS is for, and that is for biopsy purposes, not for telling you yes or no you have cancer. So I think that's like a really important thing and something that I find helpful, so I just throw it out to people. Question I have for you is, you dropped out macrocalcifications, and I like that. I'm a fan of that because I think, you know, macrocalcifications get 1 point in the TI-RADS score. What do you think the real implication of macrocalcs are in terms of cancer risk? Because you're dropping it out, and I agree with you, but I'm curious what you guys think.
Yeah, thank you so much for your comment. With regards to your first comment, I completely agree, and that was kind of one of our biggest motivations for doing this study, is for its role in patient education. And, you know, when patients come in, seeing their radiology report, knowing that it says it's a highly suspicious nodule for malignancy, we wanted the data to be able to say, hey, at our institution, you know, over 85% of these nodules end up being completely benign. So you have that tool to counsel patients on. And then with regards to your second question, I think the data in the literature seems to kind of go back and forth. I think it's highly agreed upon that microcalcifications are indicative of a risk of malignancy, but there's some contradictions in terms of if macrocalcifications are truly increasing your risk of malignancy or not. Other quality improvement type studies have also found that dropping out macrocalcifications can improve the specificity of the TI-RADS system. So I wonder, you know, it's hard for me to say what the true malignancy risk is, but I also wonder how the variability in how interpreters are reading, you know, macro versus microcalcifications are playing into how we are assessing the malignancy risk. I hope that helps answer your question.
I'm sorry, we're out of time, and you are the program director, program coordinator. But she's a medical student. Really nice job.
Thank you so much.
Now we're going to hear from Dr. Robbie Wood's paper from Dr. Ganley's group at Memorial. And while we're calling up the presentation, which is virtual, Robbie, I'm so sorry I forgot to mention you in my introductory talk. I had it in there and got too flustered.
Morning, and thank you for inviting me to present this research at the American Association of Endocrine Surgeons meeting. I'm presenting on behalf of the Head and Neck Department at Memorial Sloan Kettering Cancer Center. I'm presenting on surgical management of T1 and T2 node-negative papillary thyroid carcinoma with tall cell histology, and asking the question, is lobectomy enough? We have no disclosures to report. Papillary thyroid carcinoma usually carries an excellent prognosis. Hence, more conservative approaches are now favored. Tall cell variant is considered intermediate risk on ATA guidelines. It is unclear if patients with low-stage tall cell tumors require aggressive treatment. Although many variants are around these days, tall cell is not a variant of COVID. On the right-hand side here, you can see typical histology of classical papillary thyroid carcinoma with cuboidal cells lining papillae. On the left-hand side, you see these elongated follicles with cells whose height is at least twice their width. Similarly, in the top two slides here, you can see the classical arborizing papillae of normal PTC, and on the right-hand side, a close-up view showing the typical papillary, typical nuclear features of papillary thyroid carcinoma. On the lower two pictures, on the left-hand side, you can see the characteristic elongated follicle between the two arrows, and on the right-hand side, you can see again, tall cells with eosinophilic cytoplasm. Recent data has supported the use of lobectomy for low-stage papillary thyroid carcinoma. There is increased morbidity with total thyroidectomy, with the need for taking thyroid supplementation and potential increased risk of damage to recurrent laryngeal nerve or parathyroid glands. Some papillary thyroid carcinomas are now managed by active surveillance in some institutions, even for tumors up to 2 centimeters in size. Our aim was to establish whether outcomes from limited thyroid resection for node-negative T1 or T2 tall cell tumors can be equivalent to those for classical papillary thyroid carcinoma. So we had patients from our departmental database of differentiated thyroid cancers treated surgically over 30 years, which amounted to over 6,000 patients. We used the classification of greater than 30% tall cells to be considered for tall cell variant as per WHO criteria. All patients with T1, T2 tumors that had no clinical evidence of regional nodes or distant metastatic disease were identified. Patients that underwent a limited thyroid resection in the form of lobectomy, lobectomy with isthmusectomy, or thyroid isthmusectomy alone were included. Patient and tumor characteristics were compared, and survival and recurrence outcomes were measured. All patients received preoperative ultrasound scanning. Intraoperative evaluation of the central compartment was carried out, and postoperative annual thyroid ultrasound and thyroglobulin levels were measured for a minimum period of 5 years, with follow-up shared between surgeon and endocrinologist. There were 3,907 patients out of our cohort with T1 or T2 and node-negative disease. 59 of these patients underwent early completion thyroidectomy for a variety of reasons. 12 of these were toll cell variant and 14 were classical PTC. Some of these included gross extrathyroidal extension, loss of multifocality, patient preference, and in earlier cases in the cohort, some who had toll cell histology. Thyroid lobectomy or isthmusectomy alone was performed in 996 patients. 429 of these were classical PTC, and 70 were toll cell variant. There were significantly more toll cell cases that demonstrated no or partial encapsulation compared to classical PTC. Similarly, 31.4% of toll cell variant cases demonstrated microscopic extrathyroidal extension compared to only 11% of classical papillary thyroid carcinoma patients. This was significant. There was no significant difference in tumor stage, age of presentation, vascular invasion, or multifocality. And this is shown here in a table demonstrating the differences in stage, microscopic ETE, vascular invasion, focality, and encapsulation. You can see here the significant variables. There were 223 patients that were pathologically in 0, and 276 that were clinically node negative. In those that had lymph nodes removed in those 223 cases, most only had a small number of nodes removed between 1 to 4. There were a few cases that had more than 5 nodes removed, and some that had limited lateral neck dissections. Regarding T2 tumors, there were 56 toll cell variant cases that had stage T2 that were node negative. Of these, only 5 out of the 56 underwent thyroid lobectomy. In classical PTC, 35 out of 194 T2 cases that were node negative underwent thyroid lobectomy. This limits the results regarding the T2. For toll cell variant, median length of follow-up was 44 months, and for papillary thyroid carcinoma, median length of follow-up was 67 months. The difference in this reflects the fact that toll cell variant lobectomies were carried out more recently. Toll cell variant tumors had a 5-year overall survival of 97.7% compared to classical papillary thyroid carcinoma with an overall survival of 95%. 10-year survival was 92% in toll cell variant and 88.5% in classical PTC. There were no recurrences in the toll cell group. This is a Kaplan-Meier survival curve, which shows that there was no significant difference in overall 10-year survival, and there was no significant difference in local regional recurrence-free probability. Disease-specific survival was 100% in both groups. There were no recurrences locally or in the central neck in either group. Contralateral lobe recurrence occurred in 9 classical PTC cases. 8 of these underwent completion thyroidectomy at a median of 98 months post initial surgery, and 1 patient underwent active surveillance. There were 5 lateral neck recurrences in the classical papillary thyroid carcinoma group. There were no recurrences seen in the toll cell variant group in the contralateral lobe or in the lateral neck. We know that there has been an increase in clinically occult early-stage thyroid cancers, but this has not led to a change in survival. Thyroid lobectomy reduces the potential for surgical morbidity compared to total thyroidectomy. Of note, there has been an increase in toll cell variant tumors due to changes recently in the WHO criteria. Toll cell variant tumors have been reported to demonstrate more aggressive characteristics and have been associated with worse outcomes, but it is unclear if this applies in low-stage disease. Ultimately, we have a simple message. Toll cell variant cases show a higher rate of aggressive features such as microscopic extrathyroidal extension and lower rates of encapsulation, but limited thyroid resection alone leads to comparable outcomes to classical pituitary thyroid carcinoma in T1 node-negative tumors. These are some of our references, and I'll take some questions.
Thank you. Oops. Thank you. This excellent paper is open for discussion. Is that Dr. Jacob Molam?
It is. Jacob Molam from Rochester, New York. Thank you very much for this presentation. Just a quick question about your patient groupings initially. In my institution, we fairly commonly see patients who are diagnosed with papillary thyroid cancer with tall cell features, which typically is defined as having less than 40% tall cell prevalence within the specimen. Did you separate those out at all in your analyses, and how did you define tall cell carcinoma? What definition did you use for that?
Thanks. Yeah, there's been a great variation in the literature as to what's been defined as tall cell, with different percentages used to determine what should be considered tall cell. We used the most recent WHO criteria, which is greater than 30% tall cells. This is a change from what the previous criteria was at 50%. So ours were greater than 30% tall cells.
Dr. Sippel?
Hi, Rebecca Sippel from the University of Wisconsin. I enjoyed your talk. I may have just missed it, but can you explain to me a little bit about the nodal? A large number of the patients you mentioned negative nodes or had a nodal dissection. So is your approach to do a lobe and a central neck dissection, and then if it's negative, it's okay to just leave it at that? And then if it's positive, you would do more extensive surgery? Because you had said that everyone was node negative who had had lymph nodes removed, and that just seems that unlikely that there wouldn't be at least one patient with some microscopic nodal disease. So can you just explain the selection criteria based on the nodal dissections?
Yeah, thank you. We included basically only node negative patients, or clinically or pathologically node negative patients who had lobectomy. So as you know, when you remove the thyroid lobe, you sometimes take a prelaryngeal node or a couple of nodes around the thyroid, and sometimes just inadvertently there are some lymph nodes with the specimen. So the majority of the patients who had nodes removed, of the 223, had between 1 and 4 nodes taken out, which were really just usually 1 or 2 nodes that were in with the specimen. There were a small number of cases that had a central neck or central and very limited lateral neck dissection when we delved into the data, because they may have had punctate echogenic foci and nodes on preoperative imaging, and then had an FNA that was negative, but there was suspicion, so they underwent a very limited neck dissection. And yet these patients preferred conservative approach with lobectomy to preserve the other side. So the option was there to send a frozen section and proceed to total thyroidectomy if there was a node in the specimen, or a positive node in the frozen section. But the reason that we have 223 patients that had pathologically node negative were mostly because there were just a couple of nodes removed with the specimen, not necessarily that there was no positive nodes. Anyone that had a lobectomy that had positive nodes either went on to have total thyroidectomy or completion thyroidectomy or total thyroidectomy at the time, but we only included those that had pathologically or clinically node negative, were node negative in association with their T1 or T2.
So just related to that, what's the denominator then? How many people had nodes that were positive, that like of all your tall cell variant in the size?
I don't have the numbers with me right now, but we have done a separate study on all T1 tumors, whether nodes were involved or not. I don't have the numbers to hand with me right now.
We have time for one last question over here. Go ahead.
Hi, Vivian Shao, University of Wisconsin-Madison. Thank you for your great talk. I have 2 questions. Since this was a retrospective study, was the study, first of all, adequately powered to detect a difference between the 2 groups with 70 cases of tall cell and 429 of classical? And then a second question was, were you able to look at the rates of reoperation in either of these 2 groups? So especially since you found extrathyroidal extension was more common in the tall cell variant, do you know if these patients later had a recurrence that required a reoperation? So even though survival and might have been the same, did that take into account any subsequent procedures that might have taken place that might have impacted quality of life?
So thanks very much for the question. So to answer the first question, So, you know, we had, we feel that for the T1 group that we have sufficient numbers to show that the outcomes from T1 tall cells in the thyroid lobectomy are equivalent to T1 classical PTC. For the T2, the numbers are probably too small, so we can't really apply the outcomes necessarily to all T2 cases. But we certainly feel that on the T1 side that we have sufficient numbers to compare. From the second question point of view, so there were no recurrences in the tall cell group as I presented, but there were 9 recurrences in the classical PTC group. 8 of them went on to have contralateral thyroid lobectomy at a median of 98 months post-surgery, and 1 underwent active surveillance.
Thank you very much.
Okay, we're now going to move on to the last presentation, and that's from Sally's group in Pittsburgh, and it's by Jason Liu. And the title of this talk is Association of Thyroid Cancer Molecular Profile with Tumor Phenotype and Cancer-Specific Outcomes. Jason, you ready?
Good morning. I would like to thank the program committee for the opportunity to present our work on the association of comprehensive thyroid cancer molecular profiling with tumor phenotype and cancer-specific outcomes. Our disclosures are listed here. Molecular testing has dramatically advanced the field of thyroid cancer management. Studies demonstrating the diagnostic performance and clinical application of molecular testing for indeterminate thyroid nodules have been reported. And currently, molecular testing has opened the doors for novel and viable targets to treat advanced disease. Current risk stratification systems rely on pathologic information that is available only after an initial operation. Therefore, we ask the question, can molecular testing results, which can be obtained preoperatively, be used to predict disease recurrence? Knowing prognostic information before any treatment begins could improve our ability to counsel and to care for our patients. The aim of our study was therefore to retrospectively explore whether an association was present between the molecular profiles of thyroid cancer with disease recurrence and with histopathologic features. We framed our study around the perspective of optimizing care in the preoperative setting. Reevaluating the diagnostic accuracy or clinical utility of molecular testing was not our goal. We reviewed all thyroidectomy patients who had a confirmed diagnosis of primary thyroid cancer on their final surgical specimen between 2017 and 2021, and had molecular testing as part of their routine clinical care. As shown on the right side of the screen, after our exclusion criteria, we ultimately identified 578 patients for inclusion. Operative management and the decision to obtain molecular testing follow the 2015 ATA guidelines and the 2020 AAES guidelines. We correlated molecular testing results with final surgical histopathologic features. We examined how molecular testing results correlated with disease recurrence, which for this study was defined as either biochemical or structural recurrence. We also looked at all-cause mortality, but this was overall quite rare. Unique molecular profiles were created from the 4 main categories of detectable alterations: mutations, fusions, copy number alterations, and gene expression alterations. These profiles were then categorized into 3 molecular risk groups of increasing intrinsic risk for recurrence: high, intermediate, and low. For example, cancers with an NRAS mutation paired with a TERT promoter mutation was categorized as MRG high. RET fusions were categorized as MRG intermediate, and cancers with focal chromosomal type copy number alterations were categorized as MRG low. This categorization into molecular risk groups was based on independent prior studies examining specific molecular alterations and probability of disease aggressiveness. This was also independent of final surgical histopathology, and most importantly, this grouping is separate from the ATA risk stratification system for recurrence, which relies on surgical pathology findings to predict recurrence. we identified 108 unique molecular profiles from the 578 patients studied. The proportion of patients in each MRG is shown on the pie graph to your right. The median follow-up was 19 months. 15 patients had metastasis at presentation and were excluded from analyses of recurrence. Structural or biochemical recurrence was identified in approximately 9% of patients, and approximately 1% died. Patients with MRG high cancers were more often older men. Their tumors were also larger than those of MRG intermediate and low cancers. Cancers with MRG high profiles were also more frequently more likely to be aggressive types, such as Hürthle cell carcinoma or poorly differentiated. Here are the correlations of each MRG with relevant histologic features. Looking at the red and green bars, MRG high and MRG intermediate cancers were more frequently associated with aggressive histologic features, such as lateral neck disease, vascular invasion, and gross extrathyroidal extension. On the left side is the association of the MRGs with recurrence, and on the right, all-cause mortality. There is a clear association of the MRG with biochemical or structural recurrence, increasing in a stepwise fashion from 2.1% to 32.8%. Kaplan-Meier curves were significantly different across the MRGs. When examining how each MRG recurred, MRG high cancers more likely to recur as local regional structural or distant metastatic disease. MRG low cancers, when they recurred, were all biochemical. 3-year recurrence-free survival estimates are shown here, corresponding to the Kaplan-Meier curves. On multivariable analysis, adjusting for age, sex, and tumor size, each increase in MRG was associated with stepwise increases in risk for recurrence of nearly 4 to 5-fold. Overall survival is shown here, which reflects the extremely high survival in thyroid cancer overall and our short follow-up period. Because of these low event rates, we did not perform any multivariable analyses for this outcome. Although we performed several sensitivity analyses, as shown on the left side of your screen, that demonstrated consistency in our findings, our study has several limitations that must be kept in mind. First, molecular testing was not performed on all patients, but rather obtained as part of routine clinical care following guidelines. Thus, there was a higher proportion of indeterminate thyroid nodules in our cohort. Second, as a retrospective study, treating physicians and pathologists were not blinded to molecular testing results. Last, because of the short follow-up, we included both biochemical and structural recurrence into our definition of recurrence, which we know may never ultimately become clinically relevant. Thus, continued follow-up of this cohort is needed. In summary, ThyroSeq results can be used to categorize patients with thyroid cancer into 3 groups of increasing risk for recurrence, independent of age, sex, and tumor size. The MRGs were associated with histologic features and were associated with incremental increasing risk for recurrence. These trends remained robust after sensitivity analyses. Since molecular testing can be easily obtained in a preoperative setting, the prognostic information gained could potentially be used to tailor treatment. For example, patients with MRG low cancers could be considered for lobectomy, active surveillance, or even RFA. In comparison, those with MRG high cancers should be offered a total thyroidectomy, strongly considered for prophylactic central neck dissection, and perhaps routinely staged with a CT of the chest. Certainly, multi-institutional collaborative studies are needed to test this proposed strategy. For now, our findings suggest that in the preoperative setting, molecular testing results could become another valuable tool in the greater toolkit available to us to provide the highest quality patient-centered care for our patients with thyroid cancer. Thank you for your time, and I look forward to answering any questions.
Okay, that was a very nice presentation by Jason. I'd like to open the floor for any questions. Yep.
Come on, let us have it.
Yeah, question on the right, and your name, please.
Mahsa Javed, Charleston, South Carolina.
Okay.
I think it was obviously an excellent study. I would like to hear other people's questions, honestly, but for the low-risk group, are you confident enough in these results to perhaps suggest active surveillance versus surgery?
For me personally, given that this is what we routinely practice at our institution, I actually do feel quite confident. I would certainly, for my own patients in the future, for low-risk mutations, as long as there are no other clinical signs, right? Because this is a component, a certain tool that we would use within the comprehensive evaluation of our thyroid cancer patients. If there is no other clinical risk factors that might preclude, that might encourage me to do a total thyroidectomy or to offer surgery at all, then certainly active surveillance or a lobectomy is reasonable.
Okay, we'll take a question from the left.
Nancy Cho, Boston. Hope you're feeling better, Jason. Thank you for a really nicely presented talk, and I really congratulate you on your work. I think I missed this probably earlier on in your methods. Did everyone across groups get total thyroid and radioactive iodine, or were they dependent on the profiling?
Oh, yeah, I may have, I may not have said that. Yes, our group was both thyroidectomy and lobectomy, and any sort of treatment strategies that were done, since it was a retrospective study, was just based upon guidelines and and whatever the treating surgeon or endocrinologist recommended. So there was certainly definitely heterogeneity in the treatment strategies for these patients.
Thank you.
Okay, and we'll take a question from the right.
Jason Suryaparangi from Boston. I was wondering, I'm always puzzled by my own patients with Hürthle cell cytology and then the clonal rearrangements. I noticed you put that in the low risk category, the clonal rearrangements. Was I interpreting that correctly?
So my understanding is that there are, from ThyroSeq, there are different levels of copy number alterations that would suggest either a more benign follicular adenoma with Hürthle cell features or more likely to be a Hürthle cell carcinoma. And so those were stratified appropriately. So if there was a copy number alteration that was in the high category, which was more likely to be associated with aggressive features, and those were categorized into the MRG high. And we certainly relied on our colleagues from pathology who are far more intelligent about this than I am to help us with those categorizations.
Thank you. Yeah, I think that's an important point to make, because I think weirdly not everyone reads to the bottom where those are listed, and I think it can get missed. And your research is highly in this area, so I think it's important to read all the way to the very end where those clonal rearrangements are noted, because it can be very risky, as you point out, and I think Ian's paper has that in as well. So thanks. I just wanted to clarify that.
Okay, and we've got time for one more question on the left.
Scott Grant, New York. Thanks for a great paper. You talked about assessing for biochemical recurrence and found that more in your low-risk patients. I was wondering, for people who had a thyroid lobectomy, what did you use in terms of assessing that? Because there's obviously going to be fluctuations in thyroglobulin. And similarly, what was your threshold in people who'd had a total thyroidectomy, since that is also influenced by TSH?
Yeah, so certainly for the total thyroidectomy, that's fairly straightforward, since I just followed the ATA guidelines, so anything greater than 1, stimulated, etc. But for lobectomy, since, as you point out, there really is no good threshold, I certainly used structural recurrence first. That was the first layer of defining recurrence, and if structural recurrence was not present, then we looked at biochemical. And for lobectomy, I think anything greater than about a 30 for thyroglobulin was what I used for my cutoff. But again, that was extremely, extremely uncommon, and I tended not to assign anybody in a biochemical recurrence unless they had a total thyroidectomy, just to avoid some of that heterogeneity that you've already pointed out.
Thank you.
Okay, thank you very much. Thanks, Jason, for that excellent presentation.
This concludes our session.
Okay. I'd just like to thank Sally for that awesome introduction at the very beginning. She gave a very nice summary of the topic. Thanks, Sally.